good afternoon. My name is Candace Willett. I'm the Pediatric Nurse Practitioner at the Jemsek Specialty Clinic. I'm joined with Dr. Joseph Jemsek today. Him and I will be providing a discussion on our red flags and observations observed in pre and post-adolescence. We did this topic many months ago, and we thought it was very important to bring it to the forefront again and kind of discuss the meat of the document itself, focusing on big picture questions that parents often ask me, as well as kind of talking about brain development and different stressors that play a part in early development and how infection and inflammation can impact development. Dr. J, would you like to take it away?
Thank you, Candy. So this is we're trying to take a small bite out of a very, very complex subject. We, in our previous discussion, did outline for the very first time it's ever been done, a series of observations based on stratification age. So, for example, and you'll find this on our website, Jemsek Specialty, under blog. It's the second one from the top. But we have 4 age categories, and we have this these symptoms and signs that we don't assign weights to, but if you have multiple positive checks, then we think that, in our experience of 20 years, that your developing child from pre to post-adolescence may be having some manifestations of Lyme Borreliosis Complex. And as most of you know, Lyme LBC comes in all different flavors and all different manifestations, and the immune system is bobbing and weaving with the infections, and it's a very complex subject indeed. So to help parents today, we want to just, ask Candy and her thoughts about what do parents ask, and what are they hearing from their child at home? What is the child verbalizing, and what age? What are some of the transitional stress periods? And just some common sense. Again, we're not going to do a 6-hour definitive discussion of this subject, but we do want to give some helpful hints. And by the way, on the observational piece that I spoke about that's on the website, if anyone has any constructive criticism, because we'd love to hear it, because it's a work in progress. So if you have some observations you think are important, and they do flow through from age period to age period. So if you have some observations that you think would be helpful or valid, let's hear from you.
Absolutely. Thank you, Dr. J. To start, we just wanted to focus on some of the questions that we received through Facebook Livestream, but also kind of go through some of the big picture questions that parents often present to myself, but also some of our other providers. As you know, we treat families here. And to start, parents often ask me, could I pass this infection on to my child? So we want to kind of go through modes of transmission today. And to answer that, Dr. J would like to do so.
Well, I have to sort of answer this sideways, because I don't want the Lyme paddy wagon to pick me up, but we think that clearly, if you think about it, the spirochete Borrelia burgdorferi is at the peak of the genomic chain in this family Spirochetia, and its dumb cousin is syphilis. And everyone is aware of the fact that for centuries syphilis has been recognized as being congenitally spread. There is such a thing as congenital syphilis. And so it's not a big jump to assume that this very versatile, evasive spirochete can do the same thing. That doesn't mean that the child will have a congenital borreliosis. It doesn't mean that at all, because it's much more complex than that. But let me give you a background, just descriptively, of what we see here. First of all, over the past many years, I've dealt with and worked with obstetricians for pregnant ladies who were different stages of treatment, mostly resolved and stable. And we've had a situation where we used fetus-friendly antibiotics with the approval of the obstetrician, and Monday through Friday. And we've done cord blood analysis in 200 people, and we've had 4 positive PCR, permanase positive spirochete strains. And those children, a couple of them were ill, but that means that 97 or 8% were negative. That doesn't mean it wasn't transmitted, but that's just to give you some anecdotal data from the clinic. Unfortunately, we don't have the ability to publish that. And then the other obvious fact is that we probably take care of 250 families in which a parent or both parents are known to be infected, or some other direct, closely related person. And then with their children, there's a number of children that are infected. And we have at least 250 families like that. And as families go through the family tree and the family history, they say, oh, I wonder if grandma had it because she had lupus when she was 45, or, grandpa had rheumatoid arthritis when he was 40, and we had cousins with MS and all that sort of thing. And so we can get a very rich history, and, you can't prove anything, but there certainly does seem to be a family connection.
Absolutely. And then, the other mode of transmission, which is most commonly known as vector-borne insect bites. And everyone wants to attribute the transmission to tick bite, but realistically it's other vector-borne insects that can spread. So realistically, 3 forms of transmission could be in utero from mother to child. You could have the vector-borne insect bites, and then from partner to partner. If we were to think that syphilis, the cousin to Borrelia, is sexually transmitted, the dumb cousin is sexually transmitted, then by that notion, we need to be very thoughtful about how we protect ourselves too, knowing that it's a possibility.
Well, you can't live your life in a bubble. So I call, when we talk about sexual transmission between consenting adults, I call it a guilt-free STD. It just happens. But our government agencies choose not to study this. I don't think they want to know the answer. But I would go on record as saying that I think the incidence of in utero transmission, which can be very benign and not cause any disease whatsoever, is appreciable, probably quite high, if we had the technology and the resources to actually do those studies.
Absolutely. This kind of leads us into a question that was generated from the live stream. Lots of adult Lyme patients suspect that they might have had this disease very dormant in their body, maybe even acquired it in childhood, but it remained dormant until maybe a major stressor in their life, and now they're an adult. Is this something that we see commonly?
Well, yes. I mean, I think we go back and we can only speculate, but when you see it hundreds of times, and the family can figure it out, the patient can figure it out themselves. I think I've been sick since I was a kid. You hear that all the time. Or in your case, when a mother or father or both parents are with a child, and you start asking them questions about their child in the child's history, and they start saying, "Wait a minute,
yes,
I had that, I had that going on." So, so it's a very nuanced situation. It's always about the immune system, and it's always about combinations of pathogens and other stressors. So I think of it as 3 major categories in terms of, all right, well, who's going to develop this disease and have some debilitation from it? So you can either bob and weave through life and make compensations, like working out more, sleeping more, going off gluten, de-stressing in certain ways, making choices to de-stress, and you can function fairly well until you can't, because the underlying inflammatory load is so great. But environment is the big unknown. What's our environment with 1,000 new chemicals a year coming into the environment? What's it doing to our health?
Right.
Who can answer that? I don't know. That's just an imponderable. Your lifestyle obviously is important, and then genetics, very, very much important. And I'm going to ask you why you think that in a family with siblings, where the children are maybe one or two are obviously affected and one or two are not, why do you think it counts for that?
Sure. I think, we always have to think about birth order and position in the family, and at any given time when a new child comes into the family, what's going on in the family's life at that given time. What might they be exposed to? Socially, how is the family doing? So all of these are elements, stressors on their own that can impact a child in how they manifest symptoms, if they do or not. It really is yet to be determined. And what we also see too is that even though there's commonalities between families, there really is a degree of difference between the siblings and how they're expressing symptoms. Some could remain fairly healthy if they know how to manage stress in a healthy way, if they are sleeping really well, if they're taking care of their body, and they're more emotionally developed too, versus
Right.
some of the younger
Right.
younger ones who maybe are more reliant on the older ones to do things, so they're not capable of doing
Right.
those things on their own. So many factors at play.
Right.
Yeah. This actually leads me to a question that was generated. At what point should a child with maybe minor symptoms be evaluated if we know that mom has Lyme disease? And that's a question that I get often, and again, I think it goes back to the degree of symptoms, how the child is doing, if they're continuing to develop very well and they're able to compensate in ways by maybe we fix sleep, maybe we change their diet around, we do a little bit of detox for them too. They may not require any form of treatment, kind of a watch and wait
Right.
approach.
Right.
I think you've seen that sometimes
So, yeah,
with the
so
adults.
Yeah, well, as a parent, it'd be, and we want this to be directed toward the parents because you're the decision makers, and you can be worried sick about your child, what's going to happen, the unknown, and there just aren't a lot of answers in a lot of cases, and we say it's very difficult to say, try to walk that line which says just cautious and careful observation, but no panic. And that's why we hope our signs and symptoms graded by age groups may be of some help to say, okay, this is not normal. And Candy, I want you to begin to describe a couple of things. One is the transitional periods that are tough for the child.
Sure.
And we also want to talk about family dynamics. What if there's only one parent that's involved, and what if, or as often happens, and too often, one parent disagrees that there's anything wrong, and that how do we handle that? And that's a pretty simple legal and sensible answer for that. And then, as I said, what are the transitional periods that are tough?
Sure.
And then how does a parent decide that their child should seek care? And how do they know where to go?
Absolutely.
I just want to say one other thing. So Candace has been with us for several years, and we've been blessed to have excellent pediatric nurse practitioners here at Jemsek Specialty for well over 10 years. So that is what helped us to develop our guidelines, and all that experience went into that, and experience from other providers as well. And so, so we've treated a lot of children, and with a lot of success. And we sort of have an adage that we treat the child first and then treat mom or dad later, and that usually is how it goes, because moms are moms. They care so much about their children. They care more about their children than they do themselves, quite honestly. And that's mothers. That's what they do, and what they should do, in my view. So we treat the child first, and we try to make sense of what the approach is and why we think the child should be treated. And of course, we are very judicious in our approach and very conservative. I would say that 96% of our children, would be treated with oral, post-oral therapy over a few months. We've had some tremendous success stories.
Absolutely. And that's a good transition, because I want to emphasize to parents that, just as we mentioned, a child having minor symptoms doesn't always necessitate treatment. But if treatment is necessary, our children do very well with antibiotics to address infection. They may or may not experience a 𝗧𝗜𝗠𝗘𝗦𝗧𝗔𝗠𝗣𝗦 which is an inflammatory response to bacterial die-off. That's often something that experienced more by young adults and adults older than themselves. They may just make successive improvement along the way, but ultimately they do much better. They have lived a shorter life, obviously, so exposed to much less than we are, and what we've accumulated over a lifetime. And really, children find their way to me when parents have identified to some degree there's some abnormality going on, and they've observed patterns emerging. So that's really what parents should be focused on and watching. There can be different anomalies that happen, maybe a poor night of sleep, maybe having a tantrum here and there. But when things are occurring with more regularity, experiencing poor sleep, night terrors, not sleeping very well, being kind of more emotionally labile, reporting different things like wanting to be carried, not wanting to play, appearing more tired. These are abnormals, and we can rely on our primary care providers too for support to kind of report what's going on to them and say, look, this is what I'm observing, and hopefully they can provide some guidance. But we're also here to do that, to confirm what is an abnormal and what's normal childhood. Things will fluctuate, but ultimately if patterns are emerging, that's the key here. That's when things become more concerning, and we should be looking at what's the etiology behind these symptoms, what's at play, because something maybe is simmering beneath the surface, maybe with a few tweaks to kind of help with reducing inflammation, getting them sleeping better, changing up their diet, maybe makes the biggest change for them. But ultimately, if simple things like that a primary care provider can suggest is not helping, then it's important to look towards others for support.
Right. So we want to get into some of the transitional issues and also some of the parenting issues that we've heard, I'm afraid, too often, that a parent will minimize the child's behavior and inability to function, and just say, well, you have to try harder, you should just get off the couch and go do something and go out and perform, your grades need to be better. And so it's highly critical, and there's a lot of misunderstanding about that, because this child perhaps is not having seizures, doesn't have tics or random movements, doesn't have swollen joints, but is exhausted because there's a chronic inflammatory state going on. So can you discuss a little bit about the evolution of the growing brain and the different, just as an overview of some of the different age groups and how that may affect how the child verbalizes or doesn't verbalize, some of the complaints to the parent, and perhaps even some of the things that you've commonly heard from a child trying to describe what they're feeling.
Absolutely. So very, very briefly, so that you understand brain development, the brain develops in stages, and there's a lot of rapid growth and development between the ages of 3 and 5. We have all of our structures at that time. It really is just that we're building on those building blocks, if you will, until about age 9, and then from then on, we're developing the different centers in the brain. So we want to always be thinking about that. In the early years, this is the time where they are developing the most connections in the brain, and it's really important to be emphasizing things that children are doing well and building their skills, because then those connections will continue to build. If left out, there is such a concept as pruning, so then those connections kind of die off. As our brain is continuing to develop and we're kind of approaching adolescence, the focus is more on the limbic system. Children, as you can imagine, going into adolescence too, they're leading with their emotions, if not thinking with their emotions, and using more of the amygdala, that particular area of their brain. And then over time, what they're doing is developing the prefrontal cortex or executive function. So that's what we all have as adults, and that continues to mature about until mid-20s. What's important about prefrontal cortex is those are abilities where we're thinking about how we make decisions, our impulse control, our memory, how we think things through, how we use logic and reasoning. And you can see how there's a strategy for development. So in the beginning, we're using emotions to feel out our environment. And that's also why adolescence is kind of so tumultuous, really. You've got hormones going on with puberty. You also have the development of the brain too, but at that time, adolescents, they just don't have the capacity to use the logic and the reasoning that we would. So the approach from a parent may be different, thinking about, okay, well, if my child isn't going to be using the logic and the reasoning and has the impulse control, then I'm going to maybe approach them differently too. But just so that you kind of understand the development, it helps you to be able to pick out, okay, what's abnormal behavior going on? Is my child struggling in school to understand material, retain it, be able to do their schoolwork and stay on task and pay attention and understand instruction? And that kind of leads to transitional periods. And big transitional periods for children really are the different milestones they make in general with early development, speech, walking. Then it progresses to going to school, going to kindergarten for the first time. And that really is a stage where you're determining how well the child is doing interacting with others and their classmates, and listening to the teacher, following instructions. And then from there on, you have different milestones like going to elementary school, middle school. Puberty just in itself is a big stressful transitional period for everyone. I never want to repeat it ever in my lifetime if you paid me millions of dollars, but it's very difficult. And then going to high school is another big milestone, then higher education too, from then on. And it will be very clear at any one of these stages if a child is struggling. And we can rely on our teachers too for their evaluation if we're not seeing behavior but they're exhibiting it at school, so that we could intervene quickly too, so they could be successful.
Yeah. If the teacher isn't stressed and overworked and
all of those elements,
right, all those nuances.
Yes, or doing school virtually now too.
So when I was 5 or 6, went to a Catholic school, St. Joe's, and turned out my aunt was a nun and was teaching, my aunt. And so I wore a beanie cap because I didn't think I could think without the beanie cap. So this went on for a number of weeks, and they finally said, Joey, you need to get rid of that beanie. It's really okay. You can think without your beanie. But, it's tough. And when do you think, so what would you say about if we think that a child has some organic inflammation and is being affected emotionally or in other ways, neurologically, sleep patterns, learning how to socialize and so forth, what do you see as a general pattern about what these children require because at some point I assume they have to have, they're trying to build self-esteem, right?
Sure.
Self-identity. And what do they do they require more physical comfort or attention or praise for things that they do? What do you see? And what do you see not being given to them?
Sure. I think what makes the biggest difference, and this is just aside from treatment, is really positive reinforcement too. Praising children for things that they do well and helping them correct behaviors that are maybe hindering them to some capacity, and that also applies to the school scenario too. helping children to be successful, so identifying what their needs are and then providing those accommodations so that they can be successful. Sometimes when it comes to engaging in treatment, what we focus on in the very beginning for any patient across the board is thinking about what their chronic debilitating symptoms are, and that includes what they're presenting with, whether cognitively, mood-wise, pain-wise, sleep issues. It's all, the body is very complex, and it involves many things working at once to help with mediating immune stabilization and how well and successful they would be at treatment too. So we try to think about ways always to address their needs specifically, and by encouraging and supporting parents to do those things and help them with those strategies.
Thank you. At what age period do you think that the peer pressure is the worst, and how does a child decide to be a conformist versus an individual? And what are those determinants? And is someone that has organic infection of the brain able to be an individualist?
Yeah, that's a good question. What we find often with this disease is that, as you can imagine, just as I explained, brain development, infection, inflammation may impact those areas where that child is just not developed emotionally, where they're capable of doing those things. And you're right, it would set them apart from their peers. It may create more challenges. We can rely on support from not only primary care, but also maybe extended, if a therapist might be necessary, if occupational therapy might be necessary, other support systems. But ultimately what we want to try to do is give them the tools to stabilize, to treat, and then encourage their individualism too, in a positive direction too. Because I think that will help encourage them if they are more creative, if they are very independent, if they have a voice and they use it, that it's being used in a positive direction, and they're being praised for that too.
Right. Don't we see children who have almost a gift in one area, whether it's music or
Absolutely.
writing or reading, and maybe miserable in math or vice versa, or abstract thinking and that sort of thing?
Yes.
Yeah, so we see that in the same individual doing that.
Mm-hmm.
Do you think we see it more often in our patient population than the general population?
I think we do, because if we think about this disease being a neurologic disease affecting the brain, thereby it's affecting the development of different areas and centers of the brain, and more so, some may be more developed than others, and they might have more of a predisposition in general, because genetics do play a part too in how our brain architecture develops too.
And how we detox.
Exactly. Yeah.
And yeah, so Candy, so in our adult population, and in the childhood population, we definitely see a whole range of neurologic symptoms. So you can have anything from occipital lobe, which is the movie screen in our brain, which you may be partially blind. You may have all sorts of visual disturbance. You may have cerebellar issues, which are very important with our balance and sense of where we are. And of course, the limbic system is really hammered, and that has to do with our mood, our processing, and so forth. And then the cerebrum, just our ability to think and process at higher functions is maybe severely impaired. And it could all be in the same person, but it also could be isolated issues in dominating in one person versus another.
Mm-hmm. Dr. J, maybe you could speak to how we emphasize to patients how critical the role of detox really is in our patient population specifically. You kind of touched on it, this being an inflammatory disease. Maybe you could
share a
little bit more about.
So Lyme borreliosis is, in my view, the most reliably and unfortunately predictable chronic inflammatory state known to man, other than someone with end-stage age or cancer, and those people pass on. So people may live for years with a chronic inflammatory state. As I said before, they try to compensate in different ways. And sometimes they can get the needle back to neutral if they cut out gluten, or if they get the extra hour of sleep, or if they do some meditation. And we have a self-help guide in our website that I just delivered a lecture to a UK group this last week, and actually was developed with the UK group's assistants and a couple of other individuals, to be a simple guide, again, a work in progress, but just something that anyone can do who can't access medical care, for example. And detoxification through various methods is key to that. And sleep patterns and et cetera, et cetera. Diet, very important. So when the child, so I look at this disease as damaging the electrical system in our body, which is the most sensitive system, and that would be the central nervous system, including the spinal cord and the peripheral nervous system. So any of those may be severely impacted, and they are, by definition, sensitized. So if you have a flood of toxins coming from the body because you ate spaghetti, or you had an argument and couldn't sleep for 2 nights, and you know, the toxins are going to be high. So if you have a good day versus a bad day, or a good week versus a bad week, it really has to do with the level of toxin that your body is experiencing, and those toxins excoriate this damaged and sensitized nervous system. Therefore, it's always important for child or adult to follow a low-inflammatory lifestyle, because that does 2 things. One, your quality of life will be better, whether or not you're under care. And 2, the chance for immune recovery will be much enhanced, because if you're constantly toxic due to a stressor, whether it be a psychiatric issue, a sleep issue, a pain issue, or a laboratory abnormality as a result of being chronically inflamed, that's like an anchor on your trajectory. You know, your trajectory, you're trying to improve the immune system, put the immune system in charge, and change and reverse the paradigm, so that your immune system isn't just making noise and making you miserable, but in fact it can control the infections and do so successfully. But that's a process that takes some time. Although I would say that in the children, they seem to respond more rapidly. Would you agree?
I agree. In fact, it's a good transition to share with parents how children commonly report some of these symptoms that we would maybe refer to as in medical ease, radicular pain, or symptoms where they're having musculoskeletal or neurologic impairment, and issues with mood. And I thought I'd put together some commonly reported symptoms so our parents could understand them.
Go for it.
So these are some that I've taken out of context from patients, how my little ones have reported to me.
Well, this is what the parents hear.
Yes, this is what, exactly. So this is what the parents would hear and should be thinking, okay, there's something behind this. So one is ladybugs crawling on my skin, and that's to indicate medical term formication, so having creepy crawly sensations on your body. Some have described it as fizzy bubbles on my skin, where they might feel kind of a tingling sensation, which could be more of a radicular pain as well. Kiddos have described their stomach aches as a tiger growling in my tummy, thinking about burning and the sound of the tummy gurgling. Some have said sleepy feet for when they feel numbness and tingling, and the sensation of your foot actually falling asleep, even though maybe they haven't been sitting on it positionally, which would explain it. When it comes to different night terrors and nightmares, some will say, I saw a monster in my room. They don't want to sleep in bed any longer. They want to be in your bed, or they want a parent to sleep with them. So starting to develop a little bit of separation anxiety there. Some have even spoken about, and parents have witnessed this, report of imaginary friend and them having conversations.
That will freak the parent out.
Yes, and
especially if it's continuous.
Absolutely, and comment about, the voices told me, which would scare anybody. And the one that to me really hits home the most. And so this would be indicative of kind of an out-of-body experience, kind of depersonalization. Medical term for it is, I had a child report to me that they had an experience where they traveled to heaven, and then they came back to their body. So what they were describing could have been depersonalization or a seizure-like experience where they might have lost consciousness for a moment, saw light, it appeared as heaven, and then they were brought back to their body again. So things like that. This is abnormal. Red flags to be thinking about as well too. But think about the language that children use, and they use their imagination too. And these are things that you should be paying attention to, and we could help translate them for you.
Right, and you do when the
Yes.
And I just want to reiterate the obvious, that when Candy is seeing a child, first time or on a follow-up, whatever, she is often involved with one or both parents, grandparents, aunts and uncles, siblings. So she's seeing one patient and child, but she may be seeing a dozen other people. And parents desperately want, for obvious reasons, for their child to be well. And the typical story, unfortunately, for both children and adults, is that they've been on a doctor tour, been to various doctors, some of whom, unfortunately, are not terribly understanding and quite dismissive. And that's, the child, doesn't understand that at all, and the parent just gets more and more frustrated. And so, do you think that's, at what point would a parent decide to say, well, I need to come to a clinic that treats Lyme Borreliosis, and I don't have any positive blood work, but I think I might have it, or I think my mother had it, or my father, and I just wonder if they should be seen, and is it real? And how would you convince, or not convince, but how would you paint a logical picture for that parent to say, oh, that makes sense and this is real? How does that typically happen?
Sure. Well, to start, usually how patients find their way here is just as Dr. J mentioned. They're exploring all these different options. They're seeing all these different specialists, and they're just getting closed doors. Sometimes we even hear, the specialist told me it's in my head. I've got conversion disorder. I have psychosomatic symptoms. And realistically, that's just kind of code for they don't know what's going on. And rather than just say that, they're going to give it a false diagnosis. So patients and families will come and find us saying, we don't know where else to turn. We've done our research. We think this might be it. How can you help us? And that's where we come in and do the initial consult together. It's a lengthy visit. It can go upwards of 3 hours, often less so for those who are younger because clearly they might have less symptoms, but it's a very thorough evaluation where we're going through your pregnancy history with the child. We're going through their infant history, their early childhood history, reviewing all these milestones, and you can use our document as a guide too. Now that it's public and it's listing our observations, so we may reference that during our visit together, kind of acknowledging some of the red flags, and if the child has any, we also move on to what are elements of exposure. Is it possible, based on family medical history, mom could have been impacted by this disease, dad potentially too, kind of putting the puzzle pieces together. Have they had any vector-borne insect bite to explain that? Then we really go through current symptoms, and we ask a lot of questions. We go through a thorough exam too to see if there's any abnormals. We learn a lot from the body. It doesn't lie, and it tells us what's going on specifically.
Right. So if you the exam can often tell you quite a few things.
Absolutely.
They'll say, well, did you know that your child has stria or stretch marks? Or do you know your child's joint is a little warm to touch?
Yes.
A little bit ouchy. Or your child has dark circles under the eyes, or red eyes, or a tongue that's coated. It's a sign of toxicity. Or a lymph node here or there.
Yes.
Or an enlarged abdominal organ, a liver or spleen that's enlarged. And these things add up, and then you have some physical manifestations of chronic inflammation, chronic illness, chronic streaming infections. So that's why the exam is so important. You have to touch the patient. You can't learn medicine and practice medicine without touching the patient. And just about every visit, you need to do some sort of exam because things do change.
Absolutely. And that maybe, Dr. J, you could speak on how we make this diagnosis more specifically because of testing and the availability of testing and what goes into our diagnosis.
It's a clinical diagnosis. The testing, unfortunately, is inadequate. It's a little bit better than it was a few years ago. We have a couple of new technologies, but it's still inadequate. And it's a give and take with our immune system if you look at it that way. And, you know, the laboratory is an artificial environment. I mean, they're taking reagents and they're taking bacterial strains that they think reflect the species. And it's incumbent on the immune system to be responsive. Here's the deal. We don't have any prevalence data. So if you took 100 people walking down the street, and they're not rioters, let's say, but you just took 100 people, and you had a broad selection of ages and ethnicities and so forth, and we did a certain test on them. There's no data saying that so many people are positive in such and such a test. And it's been shown some years ago that you really need a combination of testing to get your best diagnosis. This was a study done by 𝗧𝗠𝗘𝗦𝗧𝗔𝗠𝗣𝗦, I think. And but they also had to do PCR analysis of skin, which is not feasible. So, but we're all test oriented. And so one of the parents will always say, well, Timmy doesn't have a positive test, or how many bands do they need to be positive? And my doctor says they're not positive. Well, by certain criteria, which the CDC arbitrarily sets up, they may not be positive. But even if they are, I mean, what's the false positive rate for disease? Does it correlate with disease? Is the point I'm trying to make. We just don't know. We need some biologic marker that shows active replication. And even if we had a PCR, if we have a bloodstream, if we have DNA of the spirochete in the bloodstream, so, you know, who's to say that we don't have it floating through our bloodstream? Most of us, you know, from time to time, as well as a lot of other things that aren't recognized and discussed. So it becomes very problematic. Clinical diagnosis requires time and effort and education, but it is clearly the most reliable. Even the CDC says that it's a clinical diagnosis finally after putting them in a headlock a few years ago. They say it's a clinical diagnosis.
Absolutely. Which thereby, if you use that logic too, then we could surmise then that, you know, there are a lot of individuals that go undiagnosed, children, adults, families, and that the prevalence really is much higher than the data is suggesting. And if we're using clinical diagnosis and abnormal findings on exam to kind of guide us and determine this, some of the physical findings Dr. J had mentioned can also guide us where we're thinking co-infections are a possibility, and that we really do believe that our diagnosis, Lyme Borreliosis Complex, is acknowledging that this is a complex disease. It's chronic in nature, it's multisystemic, and that it involves the co-infections, not only Lyme, but we surmise Bartonella and Babesia, and then other opportunistic infections too, like a mycoplasma or chlamydia or strep, to other factors. Dr. J, would you mind just acknowledging what some of those physical findings might be to indicate maybe Bartonella or Babesia that we use as a guide?
Well, they're pretty restricted, quite honestly. It's hard to... patients, God bless them, they want to know, okay, which one caused this and which one caused that? And it's really hard to say. But Bartonella does stand out in certain ways. It's vasculopathic, meaning it loves blood vessels, but so does the spirochete, and so does mycoplasma. But it is vasculopathic, so it's probably causing most of the stria, but it's not to say that spirochete doesn't do that. And when you have these funny rashes that pop up and down, it could be Bartonella or the spirochete, most likely. It does one thing that's interesting, which is called exostosis, which is growth of new bone anywhere in the body. It could be on a digit, could be on the wrist, could be in the throat, and that's just development of new bone. And so that, or it could be on the skull, and that is a Bartonella feature. Babesia, I think I can say with great confidence, it's a streaming infection. It taxes our reticular endothelial system, which is contained in the liver and the spleen, and so the organs become enlarged. And I think we can be pretty sure, and we use this daily to assess progress, and we have expectations of when the liver and spleen will return to normal size after being congested. Now, I want to emphasize that in the vast majority of cases, the organs that are enlarged are not damaged; they're just congested. And but it is a key clinical feature. So if we find a enlarged liver, even if it's just 2 centimeters too large, if it's enlarged, it's enlarged. And so we learn to carefully palpate and examine, and that is a strong clue that they have Lyme complex. We feel that, as Candy was intimating, that all of our infections who have impactful illness, all of them have multiple infections. And now teleologically, or evolutionary-wise, why did this happen with the half dozen or 7 or 8 organisms that we're targeting? Don't know. Just it's what we see. And are there another half dozen or dozen organisms that are less virulent, that are lurking? Yes, almost certainly. Lentiviruses and other less pathogenic organisms. So, but if we hit the big 6, usually, and we do it sequentially in combinations and rolling protocols and schedules, people get better. And so complex is multi-systemic, multi-compartmental in the neurologic system, immunosuppressive, and polymicrobial.
Absolutely. And when we're doing our intake and listening to what parents are reporting too, in reviewing early childhood history too, we're gathering, has the child had a lot of ear, nose, or throat infections, indicative of opportunistic infections? What is something they've commonly been treating for? Did they have pneumonia? Did they have strep? Specifically, more the recurrent strep infections, which kind of leads me towards a question that a patient posed, because there's always this concept, and we get this question of the PANDAS and the PANDAS component, and the treating of PANDAS or PANDAS, and could strep be playing a role, and how do we typically interpret that viewpoint, Dr. J, when it comes to LBC infection?
I've always thought that the PANDAS and PANDA was in the spectrum of Lyme Borreliosis Complex. There may be a neuroanatomical site that's more predisposed, called the cingulate gyrus, which is at the top of the limbic system. And there may be some autoimmune reactivity there due to inflammation caused by the invasive organisms, the spirochete, but not so much the strep, but it may cross-react and test positive for streptococcus. Trust me, if you have an active streptococcal infection in your brain, you're dead. You're going to die. So the strep is not a gentle organism in one's brain, but yet we get strep antibodies. And also I think mycoplasma plays a bigger role in that population, and so we'll follow mycoplasma titers, although they're not terribly accurate, they're somewhat helpful. But we'll often see elevated IgM antibodies, and we'll monitor that, and we'll treat with mycoplasma active drugs more commonly. And so we do adjust our treatment program somewhat for that population.
Absolutely. And specifically, often antibiotics that we are using commonly are amoxicillin and azithromycin in our pediatric population, and they do very well with both of those antibiotics. They cover a lot, not only Lyme, but co-infections, Babesia, Bartonella, Mycoplasma, Strep. We're very thoughtful about what antibiotics we do use and how well tolerated they are. And when it comes to PANS or PANDAS, if a patient presents with that diagnosis, we don't do anything different realistically. We still would use treatment for LBC infection, but each treatment really is individualistic in some way or capacity, and involving antibiotics, as we mentioned, covering for LBC infection, but also opportunistic infections, being thoughtful that the immune system is very complex. And when the immune system is compromised and it's weakened, you have these other opportunistic infections that can capitalize on it. And we need reinforcements like antibiotics or antimicrobials or antiparasitic agents to address those other...
Or herbal products that have anti-infective.
Yes. Thank you for mentioning that. Would you mind sharing sometimes the herbal agents that we use, Dr. J, towards treatment?
So we try to take the best of the East and West. We're not just an antibiotic factory. In fact, I brought in pulsing many years ago to try to spare the body and try to follow the pathophysiology and life cycle of the target organisms. And I found that they're all slow growing, and so why treat every day? And certainly from my work with HIV/AIDS, the concept that you need combination programs is certainly something I carried forward. And there's so much toxicity that just like if with a cancer patient, there's so much die-off, there's so much cell necrosis or death, and so much waste being accumulated through the Herxheimer or through chemotherapy, for example. The body needs a rest. It needs to resolve and clear as best it can. Of course, we prep our patients for several weeks and continue to prep them on how to detoxify, what avenues are available to them, what's worked for them, what's likely to work, and how important it is to take breaks. And the breaks are when we, at some point, we measure how the immune system's doing. Because at some point, a few weeks or months into the program, all of a sudden, the weeks off, which one of my patients, Andrea, called holidays. We call them holidays. She called them holidays because the immune system's actually a little agitated, so it's firing off, but still you still get a benefit from the time off. But eventually, on the weeks off, you start to see what we want to see is the transitioning of some immunocompetence, so that the better our patient does, the less we do, and it's all about getting the immune system back in charge. And that it's a process, but that's our goal. And we want our patients to take less and less medication as time goes on.
Absolutely. As we're kind of winding down, I'm watching the clock. We're approaching 1 p.m. There's a couple questions that I think we could answer for parents that might be really helpful. We talked about how we treat, and ultimately once we reach remission is really the term that we use. We don't use the word cure because ultimately we can't fully eradicate bacteria, viruses, parasites from the body, but what we can do is focus on immune recovery. And once we get to that point, Dr. J, how would we maybe prevent the instance of relapse or reinfection? What do we usually teach our patients about that?
So for years I've done a step-down program. So immune recovery, we monitor and we step out the interval that patient's off therapy. We know that it takes about 12 months, probably a little bit less for the kids, during which time we're treating 8 days a month or 10 days a month and taking lots of breaks. And we're doing sequential programs, but always treating the spirochete in its life forms. So I think everyone that's listening knows that spirochete has multiple life forms. So not only do you have co-infections, but you got an organism that can present itself in several different ways. In any event, by monitoring and recording clinical progress, we can see that as time goes on, our patients are in a calm place, they don't feel inflamed, and they can do it for a sustained period of time. And I've termed that blue sky days. So we're looking for blue sky days, blue sky weeks. And we have expectations. We have a plan when we treat our patients. We just don't say, try this, try that. Well, let's do this, let's do that. No, we have a plan. It's not inflexible, but it is a plan. And so we have expectations. And that's important with any treatment of any disease is you have to know what to expect in terms of your treated patient or your untreated patient. So after a year of therapy, we'll go to what we call maintenance, which I've been doing from the beginning, and that's just 3 days, 4 days a month, 1 week of therapy with modest potency drugs, which are well tolerated, and we watch our patient, make sure that they remain stable. We do that for a couple of years. Ideally, and what generally happens, that our patients may react a little bit at the beginning, but then they stop reacting. That's fine. And I can only see out about 2 years after treatment, so I can't really recommend, except in those with really, really sick that got IV therapy, maybe 3 years. But I can see out about 2 years, and I know that doing this for 2 years is a very good thing to help lock in the gains that your immune system has made.
And to translate what maintenance would be for any one of our children is, it's certainly modified because, as you can imagine, they have much less symptoms, much less pervasive illness than adults would. So their form of maintenance oftentimes maybe just goes to about 6 months and then reassessing, potentially pushing out to a year or so. Again, it's individualistic. It's based on the immune system and how it's recovering. And perhaps this actually goes into maybe one of our last questions about how we keep an immune system healthy. Ultimately, how do we do it?
Well, as an ancillary to that, I'll just say that once we purge the infections, then you can heal. So I think that's a key point. So the goal is to make everything, make the treatment manageable, first of all, because if you get a patient so toxic and so overwhelmed, that doesn't really help the immune recovery, quite honestly. So our programs are designed to be manageable, and if not, we make adjustments. We go into maintenance, we keep people in maintenance, and then many folks have adopted a low inflammatory lifestyle and know it backwards and forwards. And so they continue that, and so the longer they continue that without any major skid marks in the journey, but life is life, so stuff happens, right? And but in theory, if we can go on a smooth pathway and get the time under you to be on maintenance, you can recover and you can sustain that recovery, and in many cases indefinitely.
Absolutely. In fact, if we're kind of circling back to a child's immune system too, and what we can do to keep them healthy, keep their brain developing, keep them developing emotionally and physically, we want to circle back to sleep, diet, what they're maybe doing for physical activity, what are some ways and fashion in which they're detoxing, and translation for detox is how they're reducing their inflammatory load as well, and going back to all those things, making sure that they're in balance, making sure too that they're eating healthy too, and if not, they're supplementing within that the nutrients that they need, like a multivitamin. And this actually leads me to maybe one of our last questions is that we always hear from patients. Is it a necessity? Do I have to have a primary care provider who's Lyme literate? Is that something that's a need? That's kind of one of our last questions.
No, it's not a need. It's a bonus. If we love it when our physicians take an interest, and we love it when they tell our patients, "Well, we don't know, but we want to learn." That's beautiful. I mean, patients really, really enjoy that, and we're happy to share notes with those doctors and speak with them and educate them so that they can get a sense of this new and evolving and very common illness, chronic illness. So again, it's all about getting the immune system in charge and following a low inflammatory lifestyle, and so that you can have optimal healing and recovery and get your vitality and your central nervous system back to where it was initially.
I think we have just a couple moments left, Dr. J. Earlier we were thinking of making mention of our wonderful Lyme literate therapist, 𝗧𝗜𝗍𝗦𝗦𝗧𝗔𝗠𝗣𝗦. who would have been joining us today, actually, but she is due in several weeks to have her infant, and we're very excited for her.
Oh yeah, without question.
So we're thinking of her, and we also, I use her very frequently as a reference and as a colleague for my pediatric patients when they may need talk therapy, especially to process this diagnosis, to process this disease, even when our patients have achieved remission, as we would say, and now they're processing wellness and what that would look like for them and their quality of life in the future.
Yeah, it's a long road back, but it's worth it. It's worth it.
Well, thank you so much for joining us this afternoon. We've really enjoyed discussing this document of observations that we've put together through many, many years of experience. Again, it's something that we would like you to use as a guide and to share with as many individuals as you'd like to, and certainly to also share with us if there's any additions that could be added to that list too.
Well, Candy, I want to thank you for participating and sharing your expertise in pediatric infectious disease, and specifically pediatric Lyme Borreliosis. It's been quite valuable, and I'm sure it's much appreciated by those who